All right. So it is actually 10 o'clock Eastern exactly. So I'm going to go ahead and get us started. Of course, people may be joining or coming and going as we talk, and that is completely fine. But I want to make sure that we're respectful of everyone's time today. So we will get started. So before I turn the floor over to our wonderful speaker and do an introduction, I did just want to make sure everyone knows kind of who we are as the Interstitial Cystitis Association and the host of our expert speaker series. So everyone knows this webinar is being recorded and will be shared after the fact on our YouTube channel. So welcome to those who are joining us live, but also those who are watching this after the fact on our YouTube channel. So the ICA, we've been around for over 40 years now, and we work really hard in the areas of advocacy, education, and building community. I think the important thing to know about us is that we are led by a group of people who are very passionate about serving this community, including a staff, a full board of directors, and a medical advisory council, many of whom have interstitial cystitis or bladder pain syndrome. So as I mentioned, we engage in 3 key areas. I was just talking with Ingrid before we got started about my trip to the Hill, which will hopefully happen or get started this afternoon. But we are regularly engaging in advocacy around research funding. We do a variety of things to educate our community, including this expert speaker series. And we work hard to build community, and we have a variety of online communities through social media, but we also have a new Voices of Hope patient program that we're super excited about. So just a few logistical things. If you're new to Google Meet, if it's easier for you to follow along, there is a closed captioning button at the bottom there. You can turn that on. It's actually pretty accurate. If at any point you want to share a reaction, there is an emoji button at the bottom there too. There is a chat feature. So if you think of a question during the talk, please feel free to type the question in as it comes to you, and we will do our best to come to that in the Q&A section and make sure we address your questions. If you need to adjust your settings, there's 3 little dots at the bottom there. You can click on settings, and if you want to adjust, for example, your speaker, if you can't hear it well, if it's not coming out of the right speaker, you can make those adjustments there. So just a few logistical things. I'm going to go ahead and stop presenting, and Ingrid, if you want to bring up your slides as I do a brief introduction. We are super excited today to have Ingrid Harm Hernandez with us. She has been a physical therapist for over 40 years and began specializing in women's health over 28 years ago. She was the co-director and a mentor for the Duke Women's Health Physical Therapy Residency Program, a mentor for new pelvic PTs. She's participated in research, and she is board certified in women's health and serves on a variety of committees with the American Physical Therapy Association and the American Urogynecological Society. She is a published author, and you've probably seen her on a variety of podcasts and webinars and magazines and just a whole bunch of places. So we're just incredibly fortunate to have her joining us and willing to share some expertise with us. As we know, many patients living with IC or bladder pain syndrome experience pelvic floor symptoms. So Ingrid, without further ado, I'm going to turn the floor over to you.
Thank you for that introduction, and I am so happy to be here and to be able to talk about things that I think can help people kind of find their way. So I have not to be ignored the pelvic floor and interstitial cystitis, because a lot of times, as much as pelvic floor is getting a little more known, it's still something that's not frequently talked about. So I want to kind of help people understand why it's involved and how it may possibly help. And I think if people understand a little bit better the underlying reasons, then it's easier to get the right kind of help. And that's really important. And that was a great introduction, so I don't need to spend a whole lot of time on here, but there are usually a couple points I like to bring up. So I've been a physical therapist for over 40 years now, and I've been specializing in women's now pelvic health for about 28 years. And there's that big gap there. And that's because when I started, there was no such thing as women's health, pelvic health. And it was kind of interesting when I started how I had to talk to physicians and other people, and they all thought, you got lobsters, or looked at me like I had lobsters crawling out of my ears, as if, this was a very strange thing to talk about. Well, luckily, today it is more known, but I think we still need a better understanding of it. I do talk about all different topics, but chronic pain, persistent pain is a big, big part of this. And you'll see when I list some of the different conditions out, how they can be interrelated or part of the conditions that we talk about. So it'll be good to see how that all integrates and fits together. I published a paper with the American Urogynecological Society because I felt like physicians, nurses, PAs, as much as they're immersed in the pelvic floor, they still didn't understand how to assess the musculoskeletal system correctly of the pelvic floor. And this paper really helps them understand that better, so you can get a comfortable, which is so, so important in IC and bladder pain syndrome. It's just so, so important for people to realize they don't have to have a painful exam, that a comfortable exam should be part of what everybody gets. I also published a book called The Musculoskeletal Mystery: How to Solve Your Pelvic Floor Symptoms. And that's for people to connect the dots as well. So we'll talk about why that's important. So my main goal is just to educate people, get people understanding more of what's happening in their body, whether they're a practitioner or they are just someone who's suffering with it, or they have a family member suffering with it. Everybody can understand, talk the same language, and get care. So today I'm an anatomy geek, I will confess that, but I feel like if you understand the anatomy, you understand why the pelvic floor and the pelvis and the entire core can be part of your symptoms. I'll talk a little bit about pelvic floor dysfunction, how it's related to IC and bladder pain syndrome, some pelvic assessments, so you see, well, okay, that's what will happen in a pelvic floor exam, and it's not as bad as I may have thought, because I don't want people to be afraid of going to physical therapy. A little bit about treatment, just a little touch on that, and then what can you do? What are things you can do to help? So I kind of will look at the whole big picture. And because you are part of this organization and get great information, you kind of know this first statement that I have is that it's an unpleasant sensation, pain, pressure, discomfort, perceived to be related to the urinary bladder, associated with lower tract urinary symptoms, and more than 6 weeks duration of these symptoms, and in the absence of infection or other identifiable causes. This is the American Urological Association. It's kind of their definition. But I like people to realize it often comes hand in hand with irritable bowel syndrome, painful menstruation, endometriosis, vulvar pain or vulvodynia, fibromyalgia, and prostatitis. So there are a lot of other conditions that occur with IC, and that's an important little telltale sign as well as to what is actually happening with this condition. 3 to 8 million women in the United States, 1 to 4 million in the, men in the United States, according to ICA and other resources as well. But one thing I want people to realize is it's usually not just isolated to the bladder. Recent evidence now and papers are showing that an autoimmune condition, an inflammatory condition, central sensitization, which we'll talk a little bit about, and the musculoskeletal system are often a huge part. That we have to look at all of these factors if we want to be able to resolve the symptoms. A lot of times it's not just one thing. It's not just the musculoskeletal system. It's not just an autoimmune. It's not just, it could be one, or it could be a few, or it could be all of the above. Right. So we want to look at the body as a whole. And that's a huge take home point right there, is to really look at the body as a whole. So between 74 and 92% were reported to have levator ani, pelvic floor, and I'll go through that a little bit, why that's important to understand what that is. Trigger points. And again, I'll explain trigger points as well, but it shows that's a huge, huge percentage of patients who have IC that have some kind of pelvic floor involvement. So understand that's not everybody, but it is a large percentage, so we don't want to ignore it. All right. So again, I apologize for that glitch there. So in the anatomy, what I like to do is just talk about how everything is very interconnected and how one part of our body can influence another. And that's why our bladder doesn't sit alone as an entity, but gets influenced by other structures and vice versa. So if we look, I don't, let me know, can you see my cursor as I'm showing ligaments here? I don't know
Yeah,
if
we
you're
can. Yep.
Okay, great, great. So ligaments run from bone to bone, right? And so they are our connecting source between bones. And what I like people to know is those bones and ligaments kind of are that foundation where we start to either get, support or lack thereof. So we want to make sure those units work well together. And then if we layer musculature over that, we now have another layer that helps us move, helps us with the mobility part and the stability part. And then we throw another layer on top, and that's the fascia. And we'll talk about that in a moment. That's a little bit of a structure that helps unify our organs, our muscles, everything in our body. And I want people to imagine that if you have a disruption in just one part of any of these, you can cause a disruption somewhere else. So it's kind of like pulleys and levers. If we have an irritation or a problem in one area, another area has to make up for it. And a question I love to ask my residents and students is, how many joints do we have in the pelvis? And most answers will be 3, because we have 2 SI, sacroiliac joints, and we have 1 pubic symphysis, this little joint in the front here. But then as I really think about it, what we have is 2 more joints here. Those are our hip joints, are part of the pelvis. Then we have a joint between our coccyx and our sacrum and our lumbar spine. So we have all these joints that have to move yet stay stable, and our muscles are a big part of allowing this to happen. The pelvic floor itself, let's have a good discussion on that, because the pelvic floor, the way I drew this here is this red kind of structure here underneath, and it looks a little like a sling or a hammock. All right, so think of it as this support structure. And indeed, that's one of the most important functions, is it holds our organs up. So bladder, uterus, bowels, no matter what we do every day. Then we have sphincteric. So what does sphincteric mean? We have sphincters, circular muscles around the anal opening and the urethra where we pee through. And these are under voluntary control. So what that means is they close when we don't want to pee or poop, and they open when we do. But if they get weak, or they're not functioning well, or they're too tight, we can have something like urinary or fecal incontinence as an example, or irritation to the bladder. And we'll get to that. It has a sexual function, so it allows us to have intercourse. It allows us to enjoy intercourse. It's a very important part of that whole function. A sump pump, it helps push fluid out of the pelvic cavity. That stability factor, which we'll definitely talk about, is how it coordinates with our whole core to make sure we can do whatever we need to do. And then there's a birthing function and a breathing function. So look at all those different functions, and there are more that the pelvic floor is responsible for, and it's an integral part of our core, yet with all that responsibility, there's not much recognition. So the superficial pelvic floor, very quickly, not that you need to memorize any of these muscles or anything, but just know there are 3 layers to our pelvic floor, with our levator ani being part of that. And the outer portion here has a muscle right around the vaginal opening that has to do with intercourse, and I call it the guardian of the vaginal canal. And that's important to note, especially in IC, because if this muscle tightens, it can lend itself to irritation for the bladder. It can lend itself with pain on intercourse. It can do a lot of things that create other symptoms that we may not think, well, I have IC, but I have pain with intercourse. And the 2 things don't cross over, but they absolutely do cross over. So I want people to start to realize that many things start to cross over in IC, and it's the musculoskeletal system that's part of that crossover. The ischial is the muscle here that inserts into the clitoris and the clitoral hood, part of intercourse as well. The superficial transverse perineal is like an I-beam, a support structure going across. And then we have a middle layer that is more urethral, where I was saying before, the urine, the pee passes through our urethra and to the outside. So that muscle layer has a little bit more to do with that. And then if we talk about the deeper layer, if you look at this picture, this is from the head looking down into the pelvis. So you can see that hammock or sling kind of idea from this perspective as well, and see that it's that support structure. But look at this for some examples. The piriformis, I have it asterisk, as well as the obturator internus, because they're not pelvic floor muscles, but they are so intimately connected with the pelvic floor that they can cause problems back and forth. So the piriformis is way back here. And then the coccygeus is that tail wagging. So remember before when I was showing you about the coccyx and the sacrum and the lumbar spine? Well, we have a muscle that's connected to our coccyx. It's a tail wagging muscle, can get very, very tight under stressful conditions, pain conditions, back conditions. And then the levator ani, the term that I used before, is generally considered these three here. So iliococcygeus, pubococcygeus, puborectalis. So I'm going to pick on that muscle because this is very important for IC and bladder pain syndrome. And the reason being is that this muscle connects here to the back of that pubic bone, where I was talking about the symphysis, the one joint here, and circles around the rectum and comes back down here to the bone. There are trigger points that it can occur right in here in the muscle that are right next to the urethra and under the bladder. So if this muscle is irritated, it can actually give us urgency and bladder pain type symptoms, which is one of the reasons pelvic floor PT works so well. Is if we can reduce these trigger points, we can sometimes reduce some of the urgency and the pain symptoms that come along with IC. So we want to make sure that we're addressing that and understanding that sometimes a muscle can very much mimic other pains that we have. The obturator internus. So that's this muscle here behind this white sheath, and it's connected right here to this little, what's called an aponeurosa. So it's just a fascial sheath. So it's directly connected to our pelvic floor. So a lot of people have hip problems. It causes pelvic floor problems, or pelvic floor problems cause hip problems. So we want to very much pay attention to the hip, as now you can see the joints are associated and the muscles are associated with our pelvic floor. So we want to make sure that we're understanding that some of the overactive symptoms and pain symptoms of IC actually can be the pelvic floor. I'm going to take it one step further out now very quickly. Again, no memorization of muscles, but just a point to understand a little better how everything's coordinated in our body. So the quadratus lumborum is thought of as a hip piker, but it's really a trunk stabilizer. Iliopsoas is a hip flexor, really a trunk stabilizer. And where it comes together here and joins this tendon between the iliacus and the psoas, this can create a lot of referral of pain back into the abdominal area, causing abdominal and pubic symphysis-like pain, which is also a hallmark in IC. So we want to make sure we're looking at abdominal and lower trunk and core muscles when we're looking at IC. And then the piriformis I mentioned is just another view for you, obturator internus, pelvic floor muscles. So now you can start to see how this all comes together, and we can't isolate to say it's just this or it's just this. It's rather a combination of things that are going on. The transverse abdominis is not pictured here, but I mentioned it because it's part of the core muscles, and it's a muscle that goes this way around. So think of around like this, like a corset, and it actually inserts into our low back. So it's a direct connection to our low back. So some people with IC can end up with back pain. This is one of the reasons that that's possible. And then I do like to mention the adductors because they insert right in the same place that the iliopsoas does and can sometimes cause leg pain. So before I talked a little bit about the connections and fascia. So now you're starting to see how all of this is interrelated. So when you are having hip pain and you have IC, or you're having abdominal pain or back pain, you start to understand these aren't isolated incidences, but they are all connected to one another. A trigger point that I mentioned before is a hyper-irritable locus within a muscle. So what that means is just a point in the muscle that's very thick and very aggravated. And there can be pain by just touching it, or that spot can refer pain out to other areas. So one that we just talked about before was the puborectalis, that point behind the pubic bone can refer pain up into the bladder and urethral area, mimicking those symptoms. When we talk about fascia, it covers every structure in our body, nerves, muscles, ligaments, you name it. So it really gives our body like form and function, meaning it interconnects the entire body. And this picture here, the hands across the room, when I do a presentation to an audience, what I have them do is stand up like these folks are doing here and hold hands. And I have them have one person start to pull to one side, and across the room a little while later, the person at the end feels a tug on their arm. Well, fascia kind of responds like that in our body. So we might have a tug in one body part that eventually affects the pelvis. And even more importantly, if this person steps this way and this person steps this way, the person in the middle, you can imagine, will start to feel that their arms are really getting stretched out. And I tell folks, this is the pelvis. This is what happens in the pelvis when fascia is being disrupted in other planes, in other areas, and the pelvis is what suffers. So hopefully that helps make some of those connections. And the last thing I'll talk about, because I do like to talk about the interconnectivity of the entire body, is a neurological system. And we could spend an hour just talking about this, but very briefly, we have parasympathetic and sympathetic system. Some of you may have heard of. And in our sympathetic system, that's our system that's, hey, ready to go. We have to know that if there's a bear coming, do we run away or do we fight? Do we stand our ground? And most people know about that flight or fight. There is a third component, and it's freeze. And that just means you're stuck. You don't know what to do. You can't move. You can't make a decision. Well, sometimes our system gets into override when we have pain for a long time period and we're stuck in a freeze mode. So what that means is we may do a beautiful job working on those muscles, but I need to pull in a mental health expert. I need to pull in other people, and we'll talk about that in a moment. But just realize how integrated now this system is, from top to bottom, brain down to that pelvic area, and how we really have to treat the person as a whole, how important that is. So let's talk about that core. Now that you've the foundation, there's a little bit of better understanding. And I like to think of our core as our house or our apartment building. And so our back and buttock are the back of our house. Our abdominals is the front of our house. The diaphragm here is a muscle as well. That's our roof. And here's our pelvic floor. That's our foundation. And what I want you to think is, if you get a crack in the foundation of your house, or you get some disruption in the foundation of your house, something in the house is going to start to suffer. You might get a crack, in the wall. You might start to notice something. If it gets bad enough, you're going to have serious, serious problems. Well, when we don't pay attention to the pelvic floor, those cracks could be getting bigger and bigger, and someone's trying to patch those cracks, and the cracks keep coming back. It's because the pelvic floor has not been addressed. And that's how important I think it is to make sure we're addressing the body as a whole and not ignoring the hidden structure, and that's the pelvic floor. Also, the pelvic floor and our core and our whole body is dynamic and fluid, so we don't lay on our back all day long. We connect all the way up into what's called our vocal diaphragm. So our vocal diaphragm, our breathing diaphragm, and our pelvic diaphragm are all connected embryologically, biomechanically, emotionally, every different perspective you could think of. So when we are having hoarseness or trouble with our voice, it might not be just the voice. It might not be just the diaphragm. It might not just be the pelvic floor. It could be one, it could be all three. So it's worth looking into if there's a consistent issue with hoarseness or difficulty within the throat, that we make sure we're connecting, we're making those connections. And I want everybody to think, so yes, I'm in North Carolina, and we have this beautiful lighthouse, Cape Hatteras, that a number of years ago, it was too close to the ocean. So what they did is they literally put it on rails, and they moved the entire lighthouse inward to keep it away from this erosion. And I kind of want to think of your body as that lighthouse. You're moving, and it's tremendous that this foundation for this lighthouse held everything together on this railway move, right? And that's you, that's your body, and your pelvic floor is doing that for you every single day. So let's talk a little bit quickly about conditions. And there are many, 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 many conditions that we treat as pelvic PTs. But what I like people to realize is that there are some correlations and some overlap with IC that you'll have a greater tendency to have. So today we're going to spend time on those, not the larger category. And certainly if someone has questions about that, I'm happy to answer, but we're going to stay a little bit more isolated to what you will see or you're more likely to see in IC. So urinary incontinence, it's not just an old lady's disease. It is something that happens throughout our lifetime. Pregnancy and fourth trimester is slightly more likely that it happens. As we go through perimenopause and menopause, it starts to come back again. Athletes have it, male, female, all genders, everybody can get urinary incontinence. It is not just for old ladies. Stress incontinence is an involuntary loss on coughing or sneezing or jumping or exercising. Urges, oh my gosh, it's perceived just before having to go to the bathroom or on our way to the bathroom. And when it gets bad enough, we start to get leakage. So it turns from overactive bladder sometimes into urinary urgency and leakage. And it's interesting. You don't have to have overactive bladder and leakage, but a lot of times it occurs. This research said 12 to 30% of people have it, but they feel like it's terribly underreported, and that percentage is actually far higher. With overactive bladder, it does not have to have pain associated, but with IC, it generally does. Mixed incontinence is a mixed bag of all of that. And here I just have some data. Elite athletes, 20% of female athletes have it, and it significantly increases with high impact sports. So an example would be trampoline. Over 80% of those participating in trampoline sports have urinary incontinence. So it's pretty amazing how much it happens. Fecal incontinence and constipation, less than 30% discuss this with the doctor at all. This here is from a street sign in London. And if you all can't read it that well, this here is to poop, excuse me, I'm sorry. This here, the little part of it, the white part, okay, is to wake me up. This big part is to poop. So on the streets of London, they're willing to talk about having problems with constipation, but less than 30% of people in the United States are even willing to talk about it because they feel like, well, I can just go take some kind of substance to soften my stool or, whatever it may be. And they don't really look at the underlying cause. The Rome 4 criteria is two of more of these, and there are a few others, but these are important: straining, lumpy hard stool, and fewer than 3 bowel movements per week. So you don't have to have a bowel movement every day is what's important there, right? But if you start to have less than every other day, then there's something that probably needs to be addressed. Fecal incontinence is just the loss of either flatus, so gas, liquid, or solid stool. It's all considered incontinence because the walking toots are not something we should have, right? People will have this mistaken idea that as we get older, it's okay and that happens, but no, that's an indicator there's some kind of loss of function at the pelvic floor. What happens with constipation and even fecal incontinence is there's a tendency to try to force the bowel out. And when we do that, two things happen. Either we weaken the pelvic floor further, or the pelvic floor reflexively tightens up. So every time we try to have a bowel movement, we don't realize it, but the pelvic floor starts to tighten up, and we create this cycle of pelvic floor tension, which is a lot more likely to happen in IC, is this hyperactive or overactive pelvic floor, as we call it, where the muscle tension is continuous, and it happens so regularly that we do not even know our pelvic floor is doing that until someone draws attention to it. I like to call our life more a continuum of life, and not that we go through our fertility phase and our perimenopause phase and our menopause phase. So Straw breaks that up into these groups, right? But for me, I really think we often go through kind of ups and downs over these cycles, and IC responds to that. So during pregnancy and fourth trimester, and notice I'm using the term fourth trimester, that is the period of time after birth. And here's what's so important is right now we're conditioned to say, well, 6 weeks is postpartum, and at 6 weeks, just go back to everything you were doing before. No guidance, no instructions, no, hey, we need to look at your pelvic floor. Hey, we need to look at your core. We need to look at your abdominals. That does not get discussed, right? When people often suffer with issues 6 months later, a year later, or more. So we want to make sure we're addressing things like a diastasis recti, where there's a thinning of the fascia between the abdominal muscles. And it's not a tear. So I don't like people to get frightened about that. It's a thinning of that fascia. Prolapse, that's a bulging. We'll talk about that. Incontinence and pelvic floor pain. This all occurs during pregnancy and fourth trimester. And then it can increase with what's called an assisted delivery. For forceps is something that a lot of people know. It can get better. IC can get better. It can get worse, or it can stay the same during pregnancy. Same with menopause. So we don't always know, will it go one way or the other? With my patients, I experienced the broad spectrum of changes in symptoms during this time, but it's good to be aware that there can be a change of symptoms. Something that I'll talk about a little bit later is a little bit about biome and so forth, and how that can change as well. So menopause is not just hot flashes. I want people to stop thinking of menopause as we have to deal with hot flashes. There's so many things that occur, and realize that menopause can start, or perimenopause can start as early as 35. Right? That's usually due to smoking, surgery, medications, and so forth, but it can start that early. Brain fog, joint pain, frozen shoulder are what occur during this time period. Yet nobody really talks about the correlations there and how it can definitely impact IC symptoms during that time. Menopause itself, 45 to 55, that's a decade, a big variability that can occur. And I have these pictures up there because the phases of menopause are very varied. We cannot put and lock people into, oh, it's just someone who's, 55 years old and it's a year of symptoms and, deal with the hot flashes. It's not that at all. We have a huge risk of bone mass loss. We have a huge risk of muscle mass loss. We have cardiovascular changes. In fact, cardiovascular changes and the risk of death from cardiovascular is higher than breast cancer, uterine cancer, ovarian cancer combined. A lot of people don't realize that. The musculoskeletal syndrome of menopause is a phrase that just last year was coined to help people understand better how the musculoskeletal system is involved in this, and why IC might, if we already have a musculoskeletal change, why it might react to changes that occur during menopause. Genitourinary syndrome of menopause is basically the urinary tract, anything to do with sexual function and overall health is in that category. So genitourinary syndrome of menopause, GSM, much better to say that, can have a huge impact on IC as well. And now they have one of lactation. That is just last year came out to talk about how this can occur during fourth trimester, as we were talking about. So menopause itself might not change the symptoms of IC if we're talking about just the bladder. And this paper really talked about how the biome doesn't change during menopause, which the biome is basically the good and bad bacteria of your bladder. So that's not changing. So to me, that leads us to think more the musculoskeletal system is what's changing and can impact IC. So let's talk a little bit about pelvic pain. I mentioned persistent pelvic pain. Chronic pelvic pain was a term that was bandied about for a long time, but now persistent is a little more accurate, because chronic gives a connotation that it will never go away. It's there. Where persistent means it can be there, it kind of persists, but there are things we can do about it. And I want people to realize and understand there are things to be done. So the definition is pain between the belly button and knees. It lasts more than 3 to 6 months. It can be cyclical or non-cyclical. So IC kind of fits in this broader category. For women, according to the NIH, 14 to 32%. For HWO, 4 to 26%. Men, the NIDDK says 10 to 15%. Pelvic floor can become the source of pain even if the bladder is treated. Now, really realize that if we treat the bladder and the pain's not going away, we really need to look at another possibility. And in a sizable portion of pain patients, pain is caused by a musculoskeletal dysfunction. So research is showing that the musculoskeletal system is huge in that. And I have down here quickly, a UTI might not be a UTI. So years ago, when they just gave antibiotics out like candy, someone could call and say, hey, I want an antibiotic because I've got a UTI. They would get a little bit better because the antibiotics have an anti-inflammatory quality, and then everything would come back. It's because it truly was never a UTI. It was the musculoskeletal system. So again, just kind of think about how we can be fooled by what's going on in our body. Here's a huge, huge list of diagnoses that we see as pelvic PTs, with and bolded out, of course, what we're talking about today, that this is huge. And some of the societies are now calling it female bladder pain syndrome as well. So terminology is constantly changing. There's always a little bit something different going on. So let's talk a little bit about physical therapy evaluation, because I want people not to be afraid to go to pelvic PT. There's nothing worse than saying, being referred and then you have no idea what's going on. So it's kind of like, I'm not so sure I really want to go through this, right? So there's a great article that states that someone who has IC or bladder pain syndrome really should be assessed for pelvic floor muscle trigger points and treated with release, which we'll talk about. So basic assessment is alike. Most PTs do is we look at posture, alignment, gait, and lumbar and hip range of motion. So if you've had PT before, some of those things that you've seen in PT, a pelvic PT may do if they feel like it's appropriate for you as an individual. What I have kind of bolded out in red here is that we often spend 30 minutes just on the subjective exam. That means 30 minutes taking your history, trying to understand what has happened over your lifespan that contributes, right? So our life isn't just a snapshot, what's happening right now, but there are many things that have happened in our history that influence our symptoms. And we need to know about that. We need to know if there is a central sensitization going on, where the brain is overreactive, so that sympathetic parasympathetic system, we're in that sympathetic freeze. Is there something going on where our brain is perceiving these signals even when it doesn't need to be perceiving those symptoms, creating this constant pain that occurs even when there's no injury or irritation at the origin? All right, we want to know that. Is there an abuse history, a pregnancy history, fourth trimester history? We need to know all about that. And I will say, I've had patients, sent to me for urinary incontinence, and I asked them about their sexual history, because it's surprising how many of them would say to me, well, yeah, I do have pain on intercourse, right? And we want to be able to address that. We want to address the whole, like I was talking about. Pelvic floor assessment, we'll talk quickly about, is also very different. And we may do some specialized tests for the SI joint, as you saw way back in the anatomy slide. We want to do palpation of the lumbar area, the hips, all through the core, trigger points, fascial tension, strength tests. And I say nose to toes. As a pelvic PT, I treated nose to toes because there was so much involvement. And I should say beyond the nose into the brain, because sometimes we had to treat the brain as much as the pelvic floor to get everything to work together the way it should, right? And a lot of people are like, why is there an apple on this slide with a bite taken out of it? And I put this slide when I talk to doctors and nurses as well, because I say to them, you look at the apple from this side, and I did this one day, took the apple, I put it down, walked away and walked back. And the apple, of course, just started to get a little oxidation, turning a little brown. And when I had seen the apple from the other side, it looked perfectly normal. It looked okay. I come back to the other side, I'm like, wow. So if you have a patient and you're only looking at the apple from the whole side, you don't see the underlying cause, and you walk around, you're like, oh boy, that bite there is going to cause a huge problem, right? And unlike the apple, we can put things back together again. The apple, that's it. But I just like the idea of that you can see that you can look at someone from one side and say everything looks great, and from the other side, not so much. So in a pelvic floor evaluation, what can you expect? So it depends totally on the PT's assessment and the patient's toleration. So what that means is if I have a patient and I explain to them what I'm going to do, and they tell me I'm not ready for a pelvic exam, I say, awesome, let's go on to do what we can do through the whole with the pelvis, address that first. And if you're ready to come back to it at another time, we can do it then. You're in the driver's seat. Right. And this is what I say to all my patients. That is consent. That is informed consent. And all pelvic PTs and really all clinicians should be doing this. So I educate first with this lovely model that you see here, and just I have my finger here kind of pointing to some of the musculature. What you saw on the anatomy slides, I have separated out here so you can see the different muscles we may assess. So we look specifically at what's happening in each one of the muscles. We look for strength, endurance, ability to respond quickly, and can that pelvic floor relax? That's huge in IC. Can that pelvic floor let go? We don't use a speculum, one glove finger. We don't use stirrups. We make this as comfortable as possible because we know you have been through many painful exams before. And if we need to go anal, I know I'm talking vaginal now, we can do anal, and the same principles apply to an anal exam. And the perfect scale is what I was talking about, strength, endurance, and so forth. This lets us be perfectly accurate with what we give a pelvic floor exercise program. And I ban the word Kegel from my clinic once we first said it in the first session, because people have such a misconception what that is. And I see we frequently have to start with relaxation. We have to teach someone to let their pelvic floor go before we can ever get them to truly try to strengthen. So treatments are these as I've listed. I'm going to touch on them briefly so you can understand what to expect. So pelvic floor exercises you can now see are very, very, very specific to an individual. They are not what you call a cookie cutter. I'm not going to give one person walking in the door the same as this person walking in the door. They are exactly to what someone may need. They're not always okay for everybody, as we talked about. We may emphasize endurance. We may emphasize relaxation, and that's bolded because that's more typical in IC. We progress as tolerated. So I have some folks that need to stay in that relaxation phase, for the majority of their treatment or even all of their treatment. And I have some that after a couple sessions, they can start working on strengthening their floor, and that's cool. We do what they need. I like people to think of the fluid through the straw idea to get an appropriate pelvic floor contraction. So what I say to folks is imagine that you have a straw in your vaginal or your anal canal. So you're not actually putting a straw in, you're just thinking about this. And you're using the muscles of the pelvic floor to pull up and inward. And then you're asking them to let the fluid fall back out of the straw. So they're imagining the fluid falling back out of the straw. So it's an up and in, and it's a back down out. Now, here's something really interesting about that. If you try to do that and you can't find your pelvic floor, meaning you're trying that and you're like, I don't, or you're doing a lot of bobbing, you're using glutes and abdominals, or you're having pain, that is a red flag that says you need to go to pelvic PT, because it means that the pelvic floor is not understanding what it needs to do. And if you try to do a bunch of pelvic floor contractions, you can make your symptoms worse, right? And so that's why I say that's a red flag. So I spend 7 pages in my book trying to have people understand what a pelvic floor contraction is, what a relaxation is, and why it's important to understand when it's okay to do which one or both, right? So, you know, that's that musculoskeletal mystery that I talk about in the book. Why it's titled that is because people don't have someone explaining that to them, so they don't understand how and why it's involved and why they should be doing one or the other or both. So therapeutic exercises can be a great variety. I find that with IC, generally the stretches and the relaxation and the yoga type exercises work the best initially, and then we can phase into other exercises afterwards. So, if you're struggling with it, I wouldn't jump immediately into strength training, although that's awesome and it's healthy. Sometimes it needs to be more the relaxation, the stretching, and the kind of the get the body to calm and get out of the freeze state before we can progress to something else. And then strength training can be awesome, can be an excellent thing to do for many reasons. Diaphragmatic breathing, wow, this is just huge in IC. So you remember before the core, and I was talking about how voice, diaphragm, and pelvic floor work together. So every breath we take influences our pelvic floor, and our pelvic floor influences our breathing. Right. So if we learn how to diaphragmatically breathe, meaning expand our rib cage, not our belly, our rib cage with a deep breath in and blow air out, we can influence what's happening at our pelvic floor and can actually calm symptoms down with the most simplistic exercise. It's so awesome. Right. Pelvic floor muscle training with biofeedback increases the probability of improving quality of life in patients with bladder pain syndrome and IC. So we're talking about the overall quality of life, not just I'm going to get rid of symptoms, but the ability to do things and enjoy your life. And pelvic floor muscle training is now considered first-line treatment in improving both symptoms and quality of life. Behavioral modifications and self-management. So there are many, many things that we can do in order to help someone with IC. And I've listed a lot of them here. What I did is timed voiding is something that a lot of people like to use, but I will say mostly with IC that doesn't work because stressing someone out about saying you have to go so far before you use the toilet again creates stressors that can make it feel like more urgency is occurring. So it can give the reverse effect. So I really don't believe in or care for timed voiding for someone who has IC. Urgency drills are huge because it gets some of that under control and it gets us to realize that sometimes some of that pain and urgency can be gotten under control and we don't need to respond by rushing to the toilet. Increasing fiber to help the bowels so we don't irritate the bladder through bad bowel movements or painful bowel movements, to avoid straining with bowel movements, and general lifting in daily activity. Toilet positioning to make bowel movements easier, and then diaphragmatic breathing, as I mentioned. Manual therapy can be across the board many things. I'll start with more the whole body because we can do that with the whole body. Joint mobilization are techniques where we get the actual joint to move better and loosen the joint up so it's freer to move and causes less restrictions and pain. Soft tissue mobilization can be strain counterstrain, which is a picture I have here where I'm moving the muscle into a very shortened phase for 90 seconds. The muscle lets go. The patient has a lot less pain afterwards. Trigger point release is getting directly on those trigger points, trying to release them to avoid both long-term or referral of pain or immediate pain on the point. Myofascial release is getting that fascia to let go. We can use what's called a Graston tool as one example of that. Scar tissue massage in the abdominal area in particular. I find a lot of my folks need scar tissue opening up to get the whole core working well, and it's better to start early. Dry needling and muscle energy techniques are just other techniques that help us work on getting all of this functioning well with as little pain as possible. Pelvic floor manual therapy. So you've heard me talk now about the pelvic floor being overactive, being tight, trigger points. There are a ton of things we can do at the pelvic floor. The therapist usually starts with the techniques and does some of the stretching and trigger point release in that bowl of muscles that I was telling you about. But we can use what are called dilators or wands, and we can teach the patient to release the points on their own. And one of the major things about pelvic physical therapy and physical therapy is we want people to be independent. So if we can teach someone how to take care of themselves, you become independent, you become empowered, you get more confidence that you can get these symptoms under control. And that helps with the entire system working well. We need to address, like I said, that entire system. Using lubrication is huge, whether it's using it with these dilator releases, using it daily to keep the tissues moist and happy, or using it during intercourse, important for all of it. Relaxation. Sometimes these internal techniques help us really point out where those muscles are struggling and we work together. So I'll often find a trigger point and have my patient do a little mini contraction, relax, And then they can see how the muscle actually lets go. So when they do it on their own, they have an awesome sense of, are they doing the right thing or not, right? Because you can't see it. So relaxed muscles just function better. And then that eventually turns into strengthening, as we talked about. And I'm going to put a little quick note in here because social media is so rampant with all sorts of information, especially in the menopause world today. But unfortunately, so the fortunate side is it gets some notoriety and understanding that things are happening. The unfortunate side is we don't always know if there's good information out there, reliable information, and information that's really going to help us, right? So I always say put a question mark at if something sounds like it's too good to be true, that should be a red flag. I need to look into this, right? There should never be this is a one size fits all. And you can already see as I was talking that we need to fit what we're doing to the individual, not to you've got IC, so I'm going to treat you like this. No, you're an individual walking into my clinic and I need to treat you as you are as a person. So these devices sometimes say, oh, you can sit on them and they'll do 1,000 Kegels a day for you and you're going to be all better. Well, let's put the brakes on that bus because as we talked about before, 1,000 Kegels a day, nobody needs to do that. And someone who's IC, that can make their symptoms much worse, but they're not going to tell you that. Okay. The other thing that's going to happen is, as I found people discussing that they've done these machines, is that they get better with incontinence, let's say for a month or two, and it all comes back. And now they paid thousands of dollars out of pocket for something that's really not helping them live their life better and teach them what to do. So it's just a warning sign. I'm picking on that because to illustrate how we really have to be careful what's on the internet. Trigger points can be specific for pain reduction. They can also be to that reduction of referred pain. The fascial release goes hand in hand with that. We sometimes have to work on getting that fascial release to get the muscles to behave better. And there's just some data right there that most recent was, significant advancements in alleviating anxiety, depression, quality of life, and sexual function by doing manual therapy. And then I put this older one in all the way back from 2001 to show that there were studies done long ago already showing that if we work on that hypotonus, that overactive pelvic floor, as I was talking about, we can get that pelvic floor calmed down and symptoms for urgency and frequency and interstitial cystitis can get so much better. And I'll throw a little thing about biofeedback because that's a question that comes up a lot. It's a tool that I like to use, but never on its own. It is an adjunct, and research now is honestly showing it's a great adjunct to therapy, but it's not something to be used just on its own. It needs that little bit of like backup information and guidance, which is what I'm doing with this patient here. Is the lower part of each graph here is the tension in the pelvic floor, this high resting tone. And as I'm verbally going through relaxation techniques, as we get to the 10th mini little contraction that she's doing, we have a more relaxed pelvic floor. So we have to teach someone how to use the biofeedback to get the best results. And that's what this is showing here. We are going to do down training, which is getting the pelvic floor to relax, or up training, which is more considered a strength training. So that's a terminology you may hear, which is why I put that in there. Here's the effectiveness of pelvic physical therapy. There's robust evidence that it's a clear benefit in a first line of treatment, that myofascial release and PT and relaxation exercise and trigger point release can have a significant improvement in 70% of patients. So that's a significant improvement. There's almost 100% of some kind of improvement. It's just 70 got significantly better. So it goes to show us that we also need to look that if that 70% got better, then that's probably really myofascially based. But that 30% doesn't mean, oh, we can't do anything. That means there are other avenues that need to be looked at. And we'll talk about the team in a moment that help reduce the symptoms for what's not myofascial or maybe needs to be broken through before we can get the myofascial system to work 100%. So this is teamwork. This is where we can get everybody better to either a maximum degree or fully if we look at this kind of coordinated care, right? What we call an interdisciplinary care model. A significantly higher proportion of women with IC, painful bladder syndrome, responded to myofascial physical therapy than just doing massage alone. And the investigators of this paper concluded that pelvic floor PT remains, the knowledge of it remains very low, even in this day and age. So it doesn't matter what your background is, the understanding is very low, which means people aren't getting the care. They don't know that the care is there for them, which is very sad. And then this is yet another paper that 70% of IC patients who are treated with manual physical therapy for 12 to 15 visits experienced moderate to marked improvement. And this is that one of the older papers where they were just investigating it and they were looking at just myofascial release and not the bigger picture of what pelvic PT does and other practitioners do to treat everything as a whole. So here are some things for you to do, some things for you to look at, some things for you to realize. So this is pelvic PT treatment and your team. So now you've heard me mention a few times how the team is really what someone with IC needs. The pelvic floor exercises may focus on the relaxation, but can progress to strengthening. So now you know that from before. We may need to look at diet. So we may suggest, well, how do you regulate your water intake to keep it a consistent so your bladder is not irritated? And the reason why I bring that up is a lot of times folks who have IC or overactive bladder don't want to drink because they're afraid to go to the bathroom. What they don't realize is they're making their symptoms worse because the urine is now getting concentrated in the bladder and irritates the bladder lining much quicker. So instead of the bladder filling like it normally should, when it's only this big, it's already sending signals to the brain that says, I'm full and I have to go. So it's a false signal because of this really concentrated urine. We want to keep it dilute. It's a hard thing for someone with IC to realize that. But once they start doing it and they combine it with these other factors and treatments that I was talking about, it can be very, very successful. Staying away from non-irritating fluids and from caffeine. And again, that's very individual. So it might be that one person responds well by taking all the caffeine out of their diet, and another one, it doesn't make that much of a difference. Again, individual, we have to find what works for them. Bladder training. So when we're talking about training the bladder, I talk more about how do we get the brain and the pelvic floor to talk nicely together? How do we stop the argument as to what's really happening and get everything to work well so someone's not running to the bathroom when they shouldn't be running and they don't need to be running. Just realize that initially it might not work that well because the system is so upregulated, so aggravated that we have to get the system to calm down before it works better. And sometimes a urogynecologist is the kind of the clinician that comes into play and helps with this bigger picture when we're talking about the bladder and what needs to be done there. With the bowel, we have to consider constipation and fecal incontinence. Now you can see how a tight pelvic floor can create problems there. We might need a GI specialist to come in the door. Sexual health, pain with intercourse can be huge with IC. We may need a sex therapist to come in and help with that. Mental health providers to get that brain to work better and give you kind of like little tips and tricks and ways to work with this whole pain cycle that helps the system calm down. The manual pelvic floor, manual work, which could be the pelvic floor, could be the hips, could be the back, could be the abdominal area, all needs to be addressed. But we may need an orthopedist to come in to make sure there isn't something, I'll give an example of a labral tear, a tear in the cartilage in the hip joint that's adding into problems. So sometimes we need to call them in. Biofeedback in conjunction with all of this. And then as we progress, I always tell folks, so with IC, unfortunately, when someone's in so much pain and they're ruled by their bladder, they stop exercising. They stop doing things that's good for their muscle health, their bone health, their cardiovascular health. And if they're going through the fourth trimester or perimenopause, menopause transition, this is the time frame where there's a big loss of muscle mass and bone health, and more for males as they get later in their life. That also occurs. It just takes a little longer. So if they've been inactive, they're risking more issues with these other body parts, right? So we want to get everybody to understand that if we can get you healthy and your quality of life up, we can address and do the exercises and activities that help us with our overall health. And that's big to me, is looking at the person as a whole and getting that overall health back. how to find a pelvic floor therapist. So this is the website. I'm guessing you can take a picture of it, or we can put it in notes afterwards if that's okay, to have people understand that you can find a pelvic PT around the country. You put this information in. Herman and Wallace also has a directory of pelvic PTs. If you're really not sure, call and ask the pelvic PT what they do and how they treat IC. Sometimes that helps alleviate some fears about going to that therapist. Whatever helps you get in the door and get the help you need, I think is just so, so very important. So I thank you so much for listening to this and understanding how important it is to look at the person as a whole, and the pelvic floor is that kind of that hidden perspective and that hidden part that doesn't get looked at, that we need to do when we're looking at the whole, that pulling in practitioners from all walks is sometimes what we need when we have IC, and that just use my book as a resource. That is, so the Musculoskeletal Mystery, How to Solve Your Pelvic Floor Symptoms, talks all about the anatomy in detail, talks all about pelvic floor treatment. It talks about self-care. How do you start taking care of yourself at home if you can't get into pelvic PT? Or can you resolve symptoms without having to go? It talks about all the teams, like everybody, who they are, what they are, and how you can find reputable resources, like I was talking about, to find your way. So hopefully this webinar helps you put all that information together and gets the care that you need as a whole human being. So thank you very much. I think I'll stop sharing screen if that's okay.
Sure.
Sorry about the glitch before, but hopefully we have a little bit of time that we can answer questions. If I didn't blow people's minds, I would love to answer questions.
Absolutely. Well, first of all, thank you. A virtual round of applause for an excellent presentation. That is just an absolute wealth of information. And not that a lot of this is terribly new to me, but I'm always struck when I hear it about how interconnected everything is, truly. And it's good to be reminded of that. So for the audience, I did put the link to the Pelvic PT locator in the chat if you want to click on that so that you've got access to it. And just as a reminder too, this was recorded and will go up on our YouTube channel. So if you want to come back to it, as I know I want to, you could absolutely do that. We do absolutely, I know we're a little over time, but Ingrid, if you're okay for another few minutes, if anyone does have a question, you are welcome to put it into the chat, or I did actually change it so that you should be able to unmute yourself and ask a question. You're welcome to do that. So we'll give people a minute or so to ask a question. One thing I'll ask, and I think if people are using the locator, they're probably in good shape, but what is the specialization or certification that you would want to ask someone? Like if you're just talking to a physical therapist and you're curious if they do this work, what is the certification you'd want to ask about?
Yeah, so you'll see a WCS, or there are some others behind their name, but realize that not everybody goes through this board certification. It is very expensive, I have to say, but that's why I said, call. So if you go on that locator site, you want to do pelvic PT or women's health PT. It's a WCS because it's still women's health certification. We're in the process of saying we need to change that because we treat everybody. But we started as women's health. So you want to do women's health or pelvic health. And then usually what comes up is, I would suggest to people, put it in a radius that you're willing to travel. So let's say you're willing to travel a 50-mile radius. You put that in, and what it'll do is it'll come up with pelvic PTs in that radius. And then quite frequently underneath is a little bit like a descriptor as to what they do and what they specialize in. And you just want to make sure that, hey, do you treat IC? What are some of the principles you use? That kind of thing. That's why I talk about it, because it gives people that kind of that information to be armed with, saying, okay, when I want to ask about it, I know what I want to ask, instead of I have no idea what should be happening. And it gives people the confidence to say, I'm doing the right thing. I know this is something that can be helpful for me.
Great. Thank you very much. I appreciate that.
Sure.
Any other questions from our attendees? You could unmute and ask, or pop it into the chat. Well, as we wrap up, I just want to say thank you again, Ingrid. That was an amazing presentation and just full of information. Thank you for being willing to share your expertise with us, and thank you to our attendees for joining. Again, come back to this as a resource on our YouTube channel, and certainly please connect with the ICA at any point. If you have a question for us, we're super easy to get a hold of. Just email us at icamail@ichelp.org. But thank you, everyone, so much, and have a wonderful rest of your day.
Thank you for having me.
Thanks all.